In this video, we shall discuss bronchial asthma. Asthma is a common disease. It affects people of all age groups. It is an allergic condition. There is usually a genetic predisposition, but environmental factors clearly play a role in triggering the disease. It is characterized by reversible airway narrowing due to bronchial muscle contraction, mucosal swelling and inflammation inside the bronchi, and increased mucus production. As a result, the patient has these symptoms: shortness of breath, cough, and wheeze. Shortness of breath is usually present for some time before the diagnosis is established. The patient may be able to identify specific triggers like dust, pollens, exercise, etc. There's usually diurnal variation and symptoms are worse first thing in the morning. There may also be day-to-day variation as well as seasonal variation. The disease may be worse at the time of change of seasons. Cough is usually dry unless there is superadded infection. Some patients have a cough predominant asthma where cough is the main symptom rather than breathlessness. Most patients have a history of an audible wheeze. So, when taking a history from the patient, we should inquire about any identifiable precipitants, diurnal variation. If there is a clear history of diurnal variation, that helps in formulating the diagnosis. We should inquire into the exercise tolerance of the patient. Some patients are particularly sensitive to exercise. The quality of sleep should be inquired into, as nocturnal awakening due to breathlessness is a marker of poor control. Gastroesophageal reflux may sometimes trigger symptoms in patients, and so, if present, should be treated. As asthma is an atopic disease or type 1 hypersensitivity reaction, other allergic conditions like eczema and allergic rhinitis may also be present, and so one should inquire about the presence of these conditions. Similarly, there may be a history of asthma and these other allergic conditions in the family. Home and work conditions should also be inquired into, as there may be specific allergens triggering the disease. Between episodes, examination may be completely normal. However, when the patient is breathless, on examination their respiratory rate may be high. They may have wheeze or rhonchi. Essentially, they mean the same thing, but wheeze is audible with naked ears, whereas the same sound, when auscultated with the help of a stethoscope, is known as rhonchi. During acute breathlessness, the percussion node may be hyperresonant. Again, when the patient is breathless, use of accessory muscles may be appreciated. During a life-threatening attack, there may be what is known as a silent chest when the breath sounds are hardly audible. When patient is suspected to have bronchial asthma, they usually undergo certain investigations. Most patients undergo a chest x-ray, which is usually normal but done mainly to exclude other diseases that may lead to breathlessness. On the right side, you see a peak expiratory flow meter. The patient breathes fast into this device and the peak expiratory flow rate is measured. If they can maintain a diary of their peak expiratory flow rates for a week, and if there is a diurnal variation with a morning dip of more than 20%, then that is suggestive of bronchial asthma. A better way of confirming the diagnosis is spirometry. Asthma is an obstructive lung disease. So on spirometry, there is an obstructive pattern. There is mainly a reduction in FEV1, the volume of air that one can breathe out during forceful expiration in the first second. That is known as FEV1, and it is reduced in obstructive lung diseases. So the ratio of FEV1 to FVC, or force vital capacity, that is the volume of air that one can expire during forceful expiration after a deep inspiration, that is known as forced vital capacity, or FVC. So the ratio of FEV1 by FVC is less than 0.7 or 70% in obstructive lung diseases. COPD is the other important obstructive lung disease. So when we get an obstructive pattern on spirometry, we need to distinguish asthma from COPD. Asthma is a condition where there is reversible airway narrowing. So this is tested by giving the patient bronchodilators, for example, salbutamol. These spirometry is repeated again, and if there is an improvement in FEV1 by more than 12%, then that suggests good reversibility and is suggestive of asthma rather than COPD. It is important to remember that when the patient is asymptomatic between these episodes, then spirometry may be normal. These are the important differential diagnoses: COPD, bronchiectasis, heart failure, and pulmonary hypertension are all causes of breathlessness. Large airway obstruction, for example, when there is a tumor in one of the major bronchi, that may not only give rise to breathlessness but also a sound that is known as stridor, but may sometimes be confused with wheeze. Pulmonary embolism and pneumothorax are causes of acute breathlessness and may be confused with acute exacerbation of bronchial asthma. Before we come to the management of bronchial asthma, it is important to familiarize ourselves with the main groups of drugs. Beta 2 agonists are drugs that act on beta 2 receptors. Salbutamol and terbutaline are the short acting beta 2 agonists, whereas salmeterol and formoterol are the long acting beta 2 agonists. Corticosteroids can be given as inhalers. Beclomethasone, budesonide, and fluticasone are the main inhaled corticosteroids. They can also be given systemically, for example, oral prednisolone or intravenous hydrocortisone. Phosphodiesterase inhibitors are another group of drugs which act as bronchodilators. It includes aminophylline, which may be given parenterally, that is intravenously, or theophylline, which can be given orally. Anticholinergics include drugs like ipratropium bromide, which is given during acute exacerbations. Montelukast is a leukotriene receptor antagonist, which is given orally. Mast cell stabilizers are not used so much these days. Cromolyn sodium is an inhaler which can be given in exercise-induced asthma. Similarly, ketotifen is a tablet which acts as mast cell stabilizers, but as we said, these drugs are not very popular now. So we should know what is known as the stepwise treatment of bronchial asthma. Here we are talking about the long-term management of asthma. We will talk about acute management in a different video. So step 1 is the use of short-acting beta 2 agonists as and when needed. So whenever the patient feels breathless, they use a salbutamol inhaler to relieve their symptoms. But if the control is not adequate, we need to step up the treatment. So if the patient has symptoms more than twice a week, or has to use the salbutamol inhaler more than twice a week, or on an average has to wake up once every week due to breathlessness, that means that there is inadequate control and we need to step up the treatment. So step 2 is addition of regular inhaled corticosteroids like beclomethasone, budesonide or fluticasone. On the top of that, the patient can use short-acting beta-2 agonist as and when needed. If the control is still not adequate, then usually we add long-acting beta-2 agonists like formoterol or salmeterol to the inhaled corticosteroids. There are inhalers available, fixed dose inhalers available where they contain both an inhaled corticosteroid as well as uh, a long acting beta 2 agonist. If the control is still inadequate, then we have to step up the treatment further. So we can either increase the dose of steroids or use one of the oral agents like theophylline or montelukast. All three of these measures can also be taken to get adequate control of symptoms. During acute flare-ups, the patient may need a short course of oral steroids. However, some patients require oral steroids on a long-term basis, so the smallest dose that is enough to achieve adequate control of symptoms should be used. Patient education is very important. We should explain to them the fact that this is a chronic disease, it's an allergic condition, and it is important to get good control of their symptoms. The goal of our treatment here is symptom control and enabling the patient to live a normal life. They should know that avoidance of allergens is an important measure that they can uh, take to avoid worsening of their symptoms. Anyone who is smoking must be counseled and helped to stop smoking. Many patients have a stigma or bias against inhalers, so we must explain to them that inhalers are the best method of drug delivery as they deliver the drug in very minute quantities but directly where they are needed, that is in the lungs, and hence systemic side effects are minimized. Inhaler technique must be explained to them and checked at every clinic visit. We will do a separate video on inhaler technique. They should also know that if their symptoms are worsening, they should seek medical help or come to the emergency department if they are acutely breathless. Thank you.